All right. Well, good afternoon. And I guess this is the last Thursday of the academic year. Obviously, a lot of transition happening tomorrow and the next week. So I've got a few cases I'm going to start off with. Let me share my screen. All right. Should be able to see my browser.
Good.
All right. So radiograph, this is from a couple of years ago. And I'm not sure if there's anything here. I don't think I would necessarily comment on anything. I believe this was just done for pacemaker placement. But now, earlier this year, there was something identified, and I think the lateral helps quite a bit in this case. So I'll let you look at both. And especially in patients that are older that have tortuous vessels, I think this area hiding behind the clavicles can be tricky. I think the lateral can help. And if you notice on the right side, it looks a little full. I would be inclined to think maybe there's increased tortuosity of vessels there, but looking at the lateral, there's definitely something in the retrotracheal space that catches the eye. This was called. Patient ended up getting a second radiograph. This is shortly thereafter, like a couple weeks, I think, before they got a CT. And I think it looks a little bit more apparent on this one. I think it's mostly just due to positioning and technique. There's less respiratory motion. And I think now you can clearly see that there's something hiding behind here, way too much to just be vessels. And so sure enough, this patient did undergo a CT. And this is a sneaky lung cancer that is one of those blind spots, potential blind spots hiding there. And I think the combination of the lateral and the asymmetry on the PA view helps. I think for me personally, I think the lateral is actually easier to see this just because we see so much, so often you see just too much stuff medially in the upper lungs on the PA view. But I think right there you can see definitely something sitting back there that shouldn't be there. So good eye test, good for the incoming fellows, something they need to get accustomed to seeing. And then that leads us to this one, which I'll show the PA view first. So in this case, in the same area, you can see there's asymmetric opacity, and here there's a little bit of mass effect on the trachea. It's maybe a goiter, but I think it sneaks down a little bit lower than one would expect. And on the lateral view here as well, you can see that there's something else in the retrotracheal space or Rader's triangle again. So what do you think this one is? Any thoughts? And I'll just say right now, it's not a goiter.
Yeah, it's probably vascular. I mean, it's so smoothly contoured. It's retrotracheal. I think it's something vascular, but I don't know. It's hard to tell.
You're correct. I don't think I've ever seen a subclavian artery aneurysm this large, but that's what this is. So this is an aneurysm off the proximal right subclavian artery. You can see the carotid is separate here. And, I don't know the rationale, or maybe it's one of those things they just saw it, so they decided they can treat it, and therefore they would. But they did treat this, and you'll see they did a combination of opening up and doing a right carotid to subclavian artery bypass graft, ligating the subclavian artery. You can see the plug here, this Amplatzer plug, and then threw a bunch of coils in the aneurysm sac itself. So we've gotten follow-up CTs. There's so much metal artifact from the plugs. I have no idea if there's any residual flow left in there, but no, I don't know. Risk of rupture, it's like 2.5 centimeters, probably still pretty low, but they decided to go in and fix it.
Travis, it's very common in older people who have a tortuous aorta to have a convexity, a mediastinal convexity in this location. That's just a tortuous and buckled right brachiocephalic artery. But those don't displace the trachea the way this one does. Otherwise, I was going to shout out that this is just a brachiocephalic artery that's buckled and maybe dilated and tortuous. But with the tracheal deviation, that didn't fit. But the lateral convexity is just fine for that condition, which is extremely common.
Yeah. Yeah, and you kind of lose it right at the thoracic inlet here.
Right.
Yeah, but yeah, that's a good observation. I hadn't really thought of it in terms of the mass effect, but I think we all, see the tortuosity in older patients in particular quite commonly.
Right.
All right, this one, I'll let people stare at the radiograph for a moment and see if there's anything you'd comment on prospectively. Obviously, that's a very leading question because I still,
Vascular asymmetry.
yeah,
Left vascular hilum or left hilum might not be normal.
right. So there is an asymmetry here, and if you're going through a stack of 100 radiographs, like I was, I mean, I did not call this prospectively. I've never called this prospectively, but so the question is, which side's abnormal? Are we going the right is reduced or the left is too much?
I'd say right's reduced.
Yeah, and
Probably got deaf or yeah.
well, this patient was referred to us with a presumptive diagnosis of CTEPH.
Yeah,
Yeah, exactly. Yeah, so you could see it's the entirety of the right lung that is, or right pulmonary artery that's involved. And yeah, I don't know if I've ever seen this much calcification within a intimal sarcoma. I mean, that's what this is presumed to be at this point.
Yeah, I was going to say, I mean, we have a couple of, I've shown a couple cases of osteosarcs, primary pulmonary osteosarcs. So I wonder if this has osteosarcomatous differentiation, which would be my guess.
It's a good thought. Yeah, well, yeah, so obviously we were pivoting for them to, not plan for doing the thromboendarterectomy for CTEPH, rather to, start to evaluate on whether this can be resected. I mean, presumptive diagnosis. Seth, would you biopsy this, or would you just go, would you do a PET MR, or just go in and take it out?
Well, I mean, so we see a decent number here, and they do surgery on them. They do it's basically an endarterectomy.
Yeah.
The outcomes are, I mean, they do better, meaning they live a few months longer, but usually not cured. Because what's amazing with this is what they show is that even though it looks like it's all RPA and maybe, this dangling part, that when they do the specimen and do the intimal resection on the left, it's all along the intima on the left as well. You're just not seeing it yet. But the answer is, I mean, I would say that this is a sarcoma and they would just treat them. But I think a PET, if they're like, oh, we have to confirm that it's a sarcoma, get a PET. But I mean, that's pretty sarcomatous.
Yeah, exactly. I suspect they'll probably go straight to surgery since we do have an experienced CTEPH surgeon here. So
is
I think we trained him.
Yeah, you did.
Is the filling defect in that superior pulmonary vein on the right just inflow, or is that tumor?
This has got to be just slow. This has got to be slow flow here, I think, just from reduced and and you can kind of get a sense of little bronchioles that are hypertrophied here too. And of course, if this were acute PE, which is not, we would expect a lot more right heart issues. So this is
even with CTEPH, you'd expect, and that's the one thing that we noticed. I have to write this up. We have so many cases of unilateral CTEPH that look like this, but look a little different. It was a CTEPH case. Or RV strain here in the sarcomas, you don't. It's just so fast developing.
Interesting.
You don't get the pulmonary microangiopathy like you get with the CTEPH patients, right? A big portion of the issue with the CTEPH patients is they get the microangiopathy as well, similar to lesions like you get in PAH. But anyways, I digress.
Yeah,
don't you think that?
I mean, I do think it's very important to look at that collection of stuff, or, of those cases and differentiate, because, we've all shown cases that are problems.
Yeah.
So, sorry, David, what were you going to say?
Was hypertrophy, or was it just systole I was seeing?
No, I think it's thick. I think it's thick. It's just not that dilated big RV. But I agree with you, Dave. David, it did look a little thick, but it's hard to it's hard to tell, but because they're cystole, but it does look thick.
Just a little.
It was there little, and I think there was even vasculature in that clot in the tumor. So. Like if you roll down into like
right in here,
right down in there you go. Like right down in the lobar, those little dots are probably little vessels, which is obviously even
right.
I mean, I would just.
Yeah, that's. I mean, I said this is a sarcoma. I mean.
Yeah.
Well, so this one's not a sarcoma. This one just came in recently. You get a little added bonus of smoke in the aortic arch. I did see a recent one, not unlike this, where somebody called a dissection. Again, when you're at the leading edge, like we've talked about, we all know this on here, but anybody that's watching again, when you're at the leading edge of the bolus and you have a lot of this laminar flow and mixing, you can't call that a dissection. It looks nothing like one. But this is a patient who has slow flow in the aorta because they do have extensive bilateral acute pulmonary emboli, and they did meet clinical criteria of massive PE. They came in, they had a recent history of a tumor being diagnosed, a brain tumor, were on chemo for their GBM and developed sudden onset of dyspnea. And I guess when they were on the scanner, their pressures were like in the 60s over teens. You can see how large the right ventricle is. They have not only reflux, but a little bit of a contrast fluid level here in the IVC. Each of those on its own, not really all that suggestive, but in this case, when you take it all together with this burden, it's pretty suggestive. And the reason I show this one, we have an interventionalist here that is a big fan of doing suction embolectomy, and this patient went straight to the IR suite. And I'll just show you the pulmonary angiogram to start, and you can see right greater than left just how much clot there is and how little perfusion there is to the lungs. And he's a big fan of this because obviously, unlike TPA, you're not risking the bleeding effects. And this is like a 20 French sheath, and then this, it's called the FlowTriever. And so it goes in, it basically, there's a suction device that sucks the clot back into this larger catheter. And so they can direct it into different lobes, but you can see after the right side just how much improvement there is. And then he went on, tackled the left side. And I guess there was one recent study that looked at this device in particular and found that there was significant decrease in patients' RV to LV and diastolic diameter after 48 hours. There was decrease in mortality with this device as well. And in this case, the patient, pre-intervention, their pulmonary artery pressure was 40, and then it dropped to like 26 millimeters. And this patient did fine after this. So I don't know. We're seeing a few of these a week now, and they're starting to be even more aggressive with patients that aren't frankly symptomatic. I'm curious if you all are experiencing the same.
Yes, lots of them. Not as many as you. Not a few a week, but we are doing a lot with this catheter, with both ones that have right heart strain and even submassive ones that are relatively asymptomatic that they're doing them for. The issue we have found is not from ours as much as some other ones where this case was clearly acute, but we have a lot of acute on chronic getting sent to us where they're acute PE, but there's also a lot of chronic clot, and you can't take out chronic clot.
Right.
And actually seen some cases of some pseudoaneurysms and damage from people trying to pull out chronic clot with one of these machines.
Yeah, and I have no financial relationship here, but it is kind of interesting to look at this video because it has these self-expanding nitinol stents that help clear out as well, and then you suction back. So I don't know.
Do you pass the clot and then pull back to pull it in or something?
Yeah, this video shows. I don't know exactly. I haven't watch the whole thing, but I'll look at it and see. But I'll stop there.
Travis, I've got a companion case to one of the ones that you showed.
Okay, me.
I do as well.
Hi, Maya.
Mine's better.
No.
So I'll get to that companion case in a minute here, but I hope people can see a radiograph on an older woman who has a lot of bone lesions here, these expansile bone lesions, and she has this rarefaction in her right humeral head. So when I take a look at this, you know, in my patient population, this looks like myeloma to me, but the bone is actually intact here. It's not, the cortex is not disrupted. And if we look at this in cross-sectional imaging, let's look at the bones here. We'll see that these ribs are expanded. Cortex is still intact. This one is particularly expanded here on the right, this sort of bubbly look to it. And then if we go up to the humeral head, you can see this cystic abnormality here. So then let's just look at the sagittal view here to look at the spine. We have a lot of disc calcification, this very soft looking disc calcification scattered throughout. And if you look at joints in general, maybe there's a little remodeling of this joint here. And let's look at clavicles on coronal view. Here you can see that the cortex is intact over the distal clavicle here. Let's look at the sternoclavicular joint here. And you'll see once again that there's little extra calcifications in a lot of these joints here. So this is all hyperparathyroidism, and these are brown tumors of the ribs and of the proximal humerus here. So this woman has primary hyperparathyroidism. Now she also has probably a component of secondary hyperparathyroidism because she does have chronic kidney disease as well. But I think she had these lesions, and our film record doesn't go back that far. She had these lesions before she had the kidney problems. So these are brown tumors. Howard has shown brown tumors before, and I've been jealous because I've seen a fair amount of renal failure, but I haven't seen that many brown tumors. But now I have some brown tumors. I was not aware of patient being part of this, but our very knowledgeable fellow gave a nice little disquisition on this case when she showed it, when she saw it 2 weeks ago, and she'd looked up a bunch of stuff about hyperparathyroidism, and that's absolutely characteristic to have these disc calcifications. It's a kind of metastatic calcification, I guess. Okay, so hyperparathyroidism and brown tumors.
All right, Travis, I can show you more cases. Sorry.
I'm sorry. Would you say, Seth?
Oh, I thought you were done. I thought you just had the one case, but I will keep quiet and let you.
Okay. This woman has asymmetry and scrawny vessels on the right. And I think she has a lateral view. Doesn't contribute much. So scrawny vessels. And let's check it out here on CT. So we'll skip down to the bottom here. And you can see that the vessels are a bit sparse. The lung is blacker on the right than it is on the left. And it seems to be that way all the way through. We have blackness and scrawny vessels on the right compared to the left. And then we get up here. At this level, we start to see what's going on here. And there's a tumor sitting here in the proximal right bronchus. Things get very dramatic on expiration because we get this dramatic ball valve effect and air trapping in the entire right lung. And now the mediastinum is shifted way over to the left because of this ball valve phenomenon. This right lung cannot empty of air, and so the mediastinum ends up shifting to the left here, and the left lung turns white because it can empty of air and tissue density goes up. So this is a presumed carcinoid. It's a young person, I think around 20. absolutely characteristic look to it, but it hasn't been removed at this point, so I can't guarantee the pathology, but everybody's lobbying for carcinoid. So here's my asymmetric case with an abnormal, a loosened right lung. In this case, it's the airways disease, not the vascular disease.
Yeah. No
That's an
lateral?
excellent case.
What?
David, no lateral
sorry?
radiograph?
There was a lateral radiograph on that one. You know, can you see it? It's probably hiding out here, or maybe up here. I can't really see it. And on frontal, I think you can, if you know what you're looking for, you can find it. It's right here. I can show you that on the coronal. It's sitting there right at the level of the carina. It's a perfect fit for the right bronchial system. So, you know, it's so perfect that on inhalation, there's enough expansion of the bronchus for air to go in, but then the airway collapses as you exhale and it seals around this thing. So it's perfectly sized to have that ball valve effect, precision machining.
Yeah.
Okay, Seth, can you hold off for one more? Okay.
I'll try.
So this person has a diagnosis of Crohn's disease, which is currently in remission. And the oldest radiograph we have shows similar findings to this. And that is we have these sort of soft blobs in the lung here and some distortion and scarring on the right, but soft blobs. And on CT, you can see that they're dense with a surrounding ground glass, very smudgy looking things. Setting, you think, could this be fungal infection or something like this? Could this be lymphoma or something like that? So they biopsied one of these lesions and they got non-caseating granulomas out of it. Now, this is not really a characteristic look for sarcoid. And in the setting of inflammatory bowel disease, Crohn's disease, I think that a granulomatous process is part of what you can see in the lung. I haven't re-reviewed this recently. This is a very recent case, but and these lesions are slowly getting smaller without any antibiotic treatment, stuff like that. So they're smaller, somewhat smaller over a period of several months. So I believe that these inflammatory lesions here, these granulomatous lesions, are probably a manifestation, a lung manifestation of the underlying Crohn's disease. When I looked it up before, there were organizing pneumonias and there were vasculitis-like lesions described in inflammatory bowel disease, but I've not reviewed that recently. So perhaps one of you people is more up to date on that and what sorts of lung lesions we could expect in conjunction with inflammatory bowel disease. Any comments would be welcome.
You can get so-called necrobiotic lesions.
Mm-hmm.
I don't know if they get to be that large, but that's a possibility, I guess.
Okay.
Yeah, I think of large
Granular-
airways involvement as one of the more common things, but you're right. The necrobiotic nodule does come up from time to time.
Okay. No, that's not a granulomatous process, is it?
Don't think so.
Okay. But that's more of a vasculitis-like lesion. Would you agree?
What, the necrobiotic nodules or something else?
The necrobiotic.
I don't know if they're vasculitis. They got the 3 rings of, anyways, I didn't think vasculitic.
Well, at the current consideration in this case is that these are related, this granulomatous process. I'll look it up and see if anybody's reported something that looks like this or has similar pathology, and I'll get back to you guys next week. Okay, and one more.
The trachea, David, in your case was narrowed in the coronal dimension.
Yeah, it looked like a saber trachea, but she did not have emphysema. So there was not underlying disease, but the tracheal wall was not thick. Pretty discrete looking,
Right.
tough looking cartilage, I think. So it doesn't look like
The granulomatous tracheitis. Yeah.
it just looks like a saber sheath.
Okay.
Okay, and one more case, just a quickie. This person came in with heart failure, acute worsening of heart failure, hypotension, had this initial radiograph for endotracheal tube placement, which is a tad low, and then got an intra-aortic balloon. It was put in from the groin. You can see the proximal marker of this 25 centimeter balloon is down here, and the marker at the tip, and we know this is the tip because it's got the faint part that goes beyond the dense part, is way high. It's way above the aortic arch, which is roughly here. So this has gone out into the right brachiocephalic artery. This is heading for the location of the aneurysm that Travis showed us earlier. So this is not the positioning that you would want for your intra-aortic balloon. You don't want that big sausage blowing up in your brachiocephalic artery. It's going to damage it. And you can see the caliber of the inflated balloon here when they pulled it back. It's still tickling the top of the arch. It should be the tip should be at the bottom of the arch, but you've got this, more than 1 centimeter balloon blowing up in the aorta. You don't want to blow that up in a subclavian artery or brachiocephalic artery, as was transiently done. Okay, so we got back to a more normal position. It should actually go a little, maybe 2 or 3 centimeters more distal. Okay, those are the potpourri. Thank you.
Thank you.
Seth, you're
Seth, I don't
muted.
think we hear you.
There we go.
Thank you.
Yeah. So this is a very classic chest radiograph finding with this rounded lobulated contour with this kind of invagination here in the region of the aorta. Looks contiguous with the aorta. Here's a nice lateral, which really is textbook classic, where you have this indentation here. So it's like this is a pseudo-coarc, which sounds like someone's shopping. Hey Travis, someone chopping food. So here's the pseudo-coarc, and what's really this guy was completely asymptomatic, but not only did he have the pseudo-coarc, but he had a dissection in his pseudo-coarc. So there you can see the pseudo-coarc. It's actually a congenital abnormality. It's not something you just see in old patients. It's an elongation of the aorta with kinking, because it can only fit into, the chest is only so small or so large, so it kinks up. And it's also associated with bicuspid valve. A lot of people think just coarctation is associated with bicuspid valve, but pseudo-coarc is as well. And this guy's valve is a little strange. Not sure if it's, you can see there's the left leaflet is very small, but nonetheless, kind of thought that was a pretty cool case. Haven't seen a pseudo-coarc in a while, let alone, and again, he was just walking around. He was completely fine, but I'm not sure what they were doing for this dissection or not, if they were going to treat it in some way.
How old a guy was he?
I think he was in his 60s, 50s.
Okay.
Wasn't that old. I mean, you can see he doesn't have much atherosclerotic disease. He doesn't, he's got no coronary disease. He was a, middle-aged, youngish guy. Might have even been 40. I would have to check the
And he did not have a bicuspid valve. People check for it, right?
Did him getting an echo to evaluate the valve, because it was kind of strange looking a little bit. And I haven't checked yet. You can see the left sinus is a little small. It's probably trileaflet. It's trileaflet. It may be just a little dysmorphic, but I'm not sure if it's bicuspid or not. Yeah, but it's
the thing about thing about pseudo-coarct is that it, and I've been trying to get the embryology on it. The arch itself is really high. It's almost a cervical arch.
Almost, and this is a pretty high one. It is almost a cervical arch.
But yeah, but I think it must involve some pieces of one of the upper aortic arches embryologically. You know, maybe parts of 3 and 2 or something like that to put it up that high. And then I think where at the bottom of the kink is actually the level of the usual aortic arch. So I think that this embryologically involves pieces of artery that normally would have gone into forming, say, the left subclavian artery. Some components of that arch that gives rise to left subclavian probably give rise to this pseudo-coarct, really high arch.
I'm not sure about the embryology, but that's interesting. Yeah, I don't.
I wish Jeff were here to comment on that because you know, he likes the embryology of the aorta.
Let's see. This was, I don't remember, what was this case? So I have a chest radiograph. Let's see if I can remember when I pulled the chest radiograph. Oh, yeah, this is a case I saw the other day. I'm like, where is there? So let me pull up the PA and lateral. So this is a guy, you can see frontal, something down here, and then on the lateral, like, oh, that's interesting. That's like a little piece of a sponge or something iatrogenic. And I'm like, that's not good. We had nothing prior on him, but he did have a prior abdominal CT a few months before. And this, sure enough, I haven't seen one in a long time. So here is the sponge or lap pad or whatever. I don't know what the hell it was, but something. And this is, so he came in with some like abdominal discomfort. And sure enough, looking at the history, he had surgery in Tijuana 30 years prior. So this is a gossypoma in the belly from a retained sponge or other pad or other surgery. I guess it's not a sponge, it's it's not, I don't think it's a sponge, it's like some sort of pad. But yeah, so I haven't seen a gossypoma in many years.
Yeah.
Just
Travis, is that a marker in it, or is that calcification, the really dense thing?
No, this is the metallic portion that you saw in the radiograph, and I think this is part of the sponge. You're talking about what is this stuff at the periphery? I mean, I'm guessing these little other things may be part of just the calcification around this process, but this is the actual surgical material that we saw in the radiograph. So yeah, just nice thing to, you know, always look. I mean, this is pretty obvious down here, but they decided not to do surgery because he doesn't want it, and he says it's only uncomfortable when someone pushes hard on it, and he doesn't want to have it taken out. But anyways, so here's a case that we've all seen before, but of course we get no history, right? We never, I don't know about you guys. Our history was cancer workup, and we're going through and we're starting to see these nice little ovoid oblong cysts along the underlying kind of structure of the lung, and you can see them along the fissures. They're subpleural, kind of peribronchovascular. And I think we all, you know, have seen enough cases of Birt-Hogg-Dube. They're especially prominent along these little accessory fissural tissue down at the bases here. And then, of course, you can start to see this here in the right upper, in the retroperitoneum in the right kidney. And you're like, oh, that's pretty nice. Nice case of Birt-Hogg-Dube. So here he already has the left kidneys gone, presumably surgical. And then here's his new tumor invading into the IVC, renal vein into the IVC on the other side. And then of course you go to the history and you just type in EPIC, you put in, you know, Birt-Hogg-Dube, and buried in one note that he had, it says, you know, patient has classic Birt-Hogg-Dube with the fibrofolliculomas and all that stuff, but a nice CT appearance for it.
Boy, that's unlucky to have tumors on both sides, and then this one like that. Wow, That's
Yeah, not. I mean, I guess they can take it out and put it in a transplant or just put you on dialysis.
Do we know the tumor type at this point?
I didn't check the tumor type on the old one or new one. I mean, it just said renal cell carcinoma. I didn't see if it was clear cell or. I didn't.
But it was. They said renal cell carcinoma.
Yes.
Okay. RCC. That's it.
This is Jeff. I had a case I saw today that had an oncocytoma and like a young woman who has Birt-Hogg-Dube. So I think they get a spectrum of tumors.
Yeah, I
Well,
have to check it. Sorry.
More often benign, or the less malignant ones are more common than RCCs.
Yeah, but they can get different ones since it is a tumor suppressor gene.
I have to look to see what the old one was. The old stuff, he just has recent imaging here. So I'm curious what the old tumor was. I'm just curious to ask you guys. I came across, this person has some form of acute lung injury superimposed on some degree of fibrosis, which is kind of hidden by the acute lung injury, presumably some acute exacerbation. But the reason someone showed this to me and I noticed something that was completely incidental and didn't mean anything in terms of the patient's issues. But look at this here. So, right, this is a calcified node. And then there's a little air in the calcified node. And it's somehow fistulized with a and I was going to ask you guys, you've probably seen this, fistulized with a bronchus here. And then you can see this thing branching. So it's some sort of, I'm assuming some sort of fistula, and this pair of lung where this bronchus supplies is very lucent. You can see it going to mediastinum. I don't know if it's some sort of fistulization between a bronchus and the node secondary to the granulomatous infection. I'm guessing the people that see more granulomatous disease, this is probably something they've seen before. Any thoughts on that?
Well, somebody showed a case last week of
that was
tuberculosis. Right.
Yeah,
that was,
TB. That was,
right.
But that was TB lymphadenitis, sort of acute, subacute.
Right, and then I showed a case earlier of the same process with cocci. So you're in San Diego. I wonder if do you think this could be a cocci node that was calcified?
Or TB. I mean, I've seen the acute mycobacterium cause fistulas with the esophagus and stuff. Yeah, I'm assuming it's some sort of granulomatous infection that led to a fistulization up here into the right upper lobe. That's old, given how calcified it is. I just hadn't seen one before, but I'm assumed all you guys have, because again, I just don't see a ton of granulomatous disease. But presumably old TB could be cocci too. Anyways, not much to add there. And this is kind of a last case, kind of a little bit of a scary thing. So here's a patient. This is her a couple months ago. Really not much to comment on. Go to the chest radiograph a few months later. I'll say that the issue is really with the aorta here. Still, I mean, I don't think anyone would call anything prospectively. Patients rotated, not the best study. She had a history of lung cancer. Here's the next follow-up radiograph. Now there's a little bit, here, let me pull them up side by side to try to compare them, see if we can do that. So again, hard to call when you're going through your list of 100 plain films, but there is some soft tissue here that wasn't there on the prior study. And again, these studies are not that far apart. Here is an MRI spine survey that the patient had just before that second radiograph, and it was, oops, let me just make sure I have the right. And it wasn't mentioned, but I understand why. It's pretty subtle. So this is a spine survey, and you can see there's, that's not the good one. Please, hopefully it's on this one here. You can see there's this here. So here's the aorta, and then you have this enhancing soft tissue sitting there. And then the patient just had a history, it was like aphasia. So got a chest CT looking for some sort of cause. I don't know what the cause would be, but
aphasia or dysphagia, Seth?
Aphasia.
Oh, sorry.
It was aphasia with difficulty swallowing. It was definitely aphasia unless it was a typo. And then here we are now. So this patient has MSSA bacteremia and has this very large, nasty-looking pseudoaneurysm developed in a very short period of time. And if you look at the prior CT, so she had a CT a few months before, and I mean, it's just normal. I mean, she's 84. So, you know, there's no penetrating ulcer or anything. So this must be an infected, you know, from her MRSA bacteremia, but very subtle. I mean, it just how rapidly it grew. So this was probably the first findings was just this little bit of soft tissue above the aorta that was normal, just on a PIC study. I mean, this was a PIC placement. Anyways.
It's probably also leaning on the trachea, though. I mean, I think there's a medial extent.
Yes, I think there is too. I think there, and that's kind of new from prior, even though again she's rotated on every study. You know, but here it is before, and she's kind of it's got that tracheal deviation already. And let's go back to even before, and she has that even before, and this is before she had everything looked pretty good. It was just kind of that weird cap. Anyways. I'll stop there because I'm sure Howard wants to show something. Or Jeff.
And Maya, I think you said you had one, right?
Yeah, I have a couple just quick radiographs, but I can also wait for next time.
Yeah, I'll wait till the end. Carry mine over next week.
Sure, I can show mine.
Okay, you should have gotten a prompt to make present. Let's see. Make presenter.
Got it. Perfect. Okay, so this was a case that seems to be kind of on the theme today, but remind me of the cases Travis was showing. And we can see here, you know, brief glance, it looks like a pretty normal radiograph, but if we look at the mediastinum, again, like Travis's earlier cases, we can see that there is a little bit too much fullness in the right paratracheal stripe, and you can see that the trachea is being deviated over towards the left. We do have a lateral, which I think doesn't help us a whole lot, partially because the arm is sort of obscuring this upper area, but because of that, we did go ahead and get a CT. And what we have in that region is the aorta, which is coming up on the right side and then crosses behind the esophagus and the trachea to descend normally on the left side. So this is just a case of a circumflex aorta. Right, we can see the branching pattern here with the right subclavian and carotid, and then the left subclavian, or sorry, the left carotid coming anteriorly and the left subclavian posteriorly.
Wow. Could you generate a coronal form?
Absolutely, yes. Sorry. So here we go, starting at the root coming up. Here we've got the carotid coming up, the subclavian on the right. Here's the left carotid coming very anterior and then crossing over.
Yeah, the nice thing is the carotid comes off near the top of the aorta, unlike double aortic arch, where it comes off the side of the ascending aorta. So you see it's right near the top there. Not quite at the top, but almost.
Yeah,
so,
pretty close.
So right arch with aberrant subclavian rather than double arch with atretic segment.
Yeah.
And you can see the ligamentum there too. I think the fibrous cord that's left over, that little soft tissue just from the tip of the subclavian right there down to the left PA. It may be easier to see on the axials.
Let's see.
Right there.
Yeah.
That little thing, I think.
Definitely. That little guy. Yeah, so I mean, this was just an incidental finding. This patient, I think, was in her early 50s and so had made it this far without knowing about it. So clearly, you know, obviously this can cause some symptoms, but seem to probably have not in this patient. But yeah, I just thought that was a nice case. And then I have one other quick radiograph. Again, on kind of a similar theme. So this was a younger patient, I think 20s or 30s. And we can see on this frontal radiograph that there's obviously an abnormal contour here along the left margin of the mediastinum, where the main pulmonary artery should be. And then another contour, a little bit more peripheral to that, in the left hilum. But if we look at the right hilum, the vessels there all look totally normal. And if we come to the lateral, right, again, sort of posteriorly, we can see this abnormal contour here. And I thought this was just a really good case of what this diagnosis is, which is the finding of pulmonic stenosis on chest radiograph. So this patient has pulmonary valve stenosis. You can see how thick those valve leaflets are. And obviously when that happens, right, the jet across that valve sort of is directed posteriorly into that left pulmonary artery, causing that to preferentially dilate, while the right pulmonary artery is often normal.
Can you display lung windows, please, just to see blood flow a little bit?
Yeah.
In the left lower lung, is there some plethora? Yeah, I suppose.
Yeah, a little bit relative to the other side.
Yeah, subtle maybe. But that's a nice example of it. Yeah, great.
Yeah. All right, those are my cases.
Cool.
Very nice.
And that one has the bonus aberrant right subclavian artery to boot there too. So,
Right.
Howard, do you want to go?
Okay.
Okay, cool. Well, I can't take mics. Yeah.
Okay, this is a trauma patient. Without any history, just looking at this, we say, yep, there's a heck of a lot of trauma. The big findings, of course, are a large pneumothorax, a lot of pneumomediastinum, air traversing the thoracic inlet, and some chest wall subcutaneous emphysema. So the history was this person was working with, as best I could tell, it was maybe an irrigation system, but I'm not really sure of that. But there was an explosion, and whatever he's working with turned into projectiles that hit him really hard in the middle of the chest, and as you'll see, fracturing his sternum. So tremendous blunt injury right to the middle of the chest. And you can see the extent of the soft tissue injury, the extent of injury to the manubrium. And then for residents, when you see that, and particularly with this history of coarse and this much pneumomediastinum, look very carefully at the airways and follow the trachea down, intact so far, but not. And then as we go lower than that, you'll see, gosh, there's a lot of airway fractures. So it's said that when you get tracheobronchial fractures with blunt chest trauma, they typically occur within 2 or 3 centimeters of the carina and affecting the proximal main bronchi. So you can see the extent of that airway abnormality, which is really severe. And of course, they took him to surgery and fixed that. So pretty dramatic case of that. Presumably just tremendous, I suppose, kind of a shear injury and pressure in the mediastinum as the etiology of this, but particularly severe in this patient.
That was one of the worst airway injuries I've ever seen, Howard.
Yeah, it looks just awful. You just scroll through.
They just primarily repaired all that?
Yeah.
Okay.
I wish I had the op note. I did, but I couldn't copy it in time for this, but it was a big operation. Yeah, as you might imagine, very big. This one fast, just curious. We've all seen and are used to seeing nowadays a leadless right ventricular pacemaker device, but this is two. So typically, this is apparently at the present time, this is investigational, in which they're treating sinus bradycardia with the right atrial and a right ventricular pacemaker leadless. And somehow they talk to each other. And this is the first one I've seen, not approved yet, but under investigation.
I just had my first case of this yesterday, and I was showing everybody. I was like, look how cool this is. That's yeah, just first one, yeah.
Yeah, it's curious. Someone asked me, what about the power to this? And I thought, oh, wait a minute, I've never thought about that. But actually, there is a battery in the devices. So somewhere in here is a battery. And of course, they're limited lifespan, I think 5 to 15 years. So eventually, if there is battery depletion, they can simply leave the old one in place, turn it off, and put a new one in. I don't think, at least presently, they try to retrieve them when battery depletion occurs. But anyway, an investigational 2-chamber pacemaker device for bradycardia. I'll save this one. Okay, this one is a presumptive diagnosis. A person with a history of a diffuse interstitial fibrosing lung disorder. So this is from November 2021. And I'll give you a feel for the extent of fibrosis. I don't know if he had a label diagnosis, but he came in acutely symptomatic. So I want to go forward to March, and I'll just close that. So in the background, of course, we have the fibrosis, but now we can see there are multifocal, multilobar, ill-defined opacities in his lungs, consistent with an acute pulmonary disorder. And no surprise that it looks like this. So we have in the background and in the lungs, multifocal, multilobar, ground glass, geographic ground glass opacities, particularly in the lower lungs. So he had the usual work, rule out infection and all those other things, but nothing really panned out. He died, so the presumptive diagnosis here, which I think is reasonable, this may be a fatal acute exacerbation of interstitial lung disease. And as far as I know, the pathology is thought to be acute lung injury, diffuse alveolar damage in this context. So certainly the imaging findings are quite consistent with that. Pneumomediastinum is present as well. Any of you guys think that that is not a reasonable presumptive diagnosis? Everything else turned out to be negative. Yeah, okay.
That makes sense.
Yeah. Okay, this is a patient that had, I'll show you the pathology report in a moment, that has a diffuse interstitial fibrosing lung disorder. In terms of the imaging features, I would place this in the category, at least with respect to UIP, as simply indeterminate. Notably, in the lower lung zones, we don't have areas of subpleural traction bronchiolectasis. There's no honeycombing. It's primarily a peripheral lung reticulation. I consider this simply just unclassifiable interstitial fibrosing lung disorder. And two interesting things, the family history. I'll make that bigger. As you can see there, family history, a mom and 2 paternal uncles. And as you can see, perhaps no surprise that although there's substantial abnormality, even on the surgical lung biopsy, no clearly classifiable category of fibrosis was identified. So not entirely classic for any of the idiopathic pneumonias. If one were to attempt classification, maybe probable UIP. And I didn't actually personally get the history of maybe an underlying telomere disorder that the pathologist apparently got. So familial pulmonary fibrosis, fibrosing lung disorder, but not readily classifiable into one of the idiopathic IPs.
How old was the person, Howard?
This person is 51.
Yeah, so young.
Yeah. Yeah.
And that goes with the telomere things. They're usually middle age or 30s to 50s. So it's mostly we reviewed a series of 35 of these telomere abnormality lung fibroses. Most of them were an NSIP pattern. A few of them were a UIP pattern, and they were, for the most part, much younger than the spectrum of people that get IPF.
Yeah.
Now, interesting, Howard, she's a dental hygienist.
Ah, let's see. Okay.
So that is an important exposure. If I remember correctly, people in the dental industry or profession have higher risk of IPF, or at least some kind of fibrosing lung disease, whether there's probably not really IPF.
But, yeah.
Don't they
can
get
be
beryllium?
exposed to heavy metal. Yeah.
Yeah, and yeah, beryllium's one too. They also get exposed to, especially the people who, if it's people who make some of the appliances. But I thought it was dentists actually are at higher risk of IPF, and I don't know if it was due to something they're inhaling. Maybe when they're drilling calcium hydroxyapatite. I don't know. I'll have to look into it.
And to David's point, one of the other large series, that a large minority of patients were unclassifiable that had familial fibrosis, and she fits that definition because of her first-degree relatives with fibrosis. So
Yeah.
regardless of the pattern or the histologic findings, they need to do an exhaustive workup. And no, she didn't go gray in her 20s or teens, and doesn't have any other histories. Do you know of?
No, I don't think so. Not that I know of.
All right.
Okay, Jeff.
That's the hour. So
Very good.
Jeff, I'll send you the video.
All right.